Good afternoon, everyone. Thank you so much for joining us today with our for our presentation with Dr. Chevalier. I am Donna Bartlett, and I am a member of the outreach team here at SunCloud Health. SunCloud Health provides integrated, nuanced treatment with residential PHP, IOP, and virtual services for adults, and PHP and IOP for adolescents ages 12 to 18, focusing on treating the whole person in Naperville, Northbrook, and Lincoln Park. If you're interested in learning more about our services, my information and my co-partner, Lori Kehoe, will also be included on the last slides for reference. To make a referral, you can obviously contact either one of us directly or call our intake number, which will be listed. And then I will also be following up with you and checking in with you. So let me talk a little bit about our presenter today. Dr. Alexander Chevalier is a board-certified adult, child, and adolescent psychiatrist who completed his medical training at the University of Wisconsin, followed by adult residency and child-adolescent fellowship at the University of Illinois in Chicago. Dr. Chevalier has worked across the lifespan in both acute inpatient psychiatric facilities as well as traditional outpatient practice prior to taking on his role as medical director of adolescent programming here at SunCloud. He has treated a wide variety of psychiatric disorders, including mood, anxiety, substance use, and neurodevelopmental disorders, with a particular focus in childhood trauma, substance use disorders, and eating disorders. This always pains me to say, but he is looking forward to a contentious year of football between the Packers and the Bears, with the Packers ending up as a superior team yet for another year. So I'll let you take it away, Dr. Chevalier.
Thank you, Donna. I appreciate it. And thanks everybody who's joining us here this Friday afternoon. I know probably a lot of other things could be doing with your Friday afternoon. So thanks so much for spending it here with us. Today, I'm going to give a relatively brief presentation on the role of mental health screening in the primary care office and just do a quick overview about what higher level of care treatment looks like. I actually find that this area is pretty under-taught in the general pediatric landscape, even in med school. And I think a lot of folks, even in the beginning of their training in psychiatry, don't get a lot of exposure to what this looks like. So depending on where you did rotations and where you trained at, you may have had limited to even no experience in some of these cases. And so just trying to put some of the basics out there. And then we will certainly have enough time left at the end to have conversations about kind of what you're seeing in your clinical practice. And if there's any questions that you have about anything we're talking here today, also happy to just talk about cases more generally or anything related to the mental health of our youth. So having said that, I just recently listened to a Freakonomics episode, which clearly outlined the worst thing you can do at the beginning of a talk is to go over objectives. I have long agreed with this. So it was awesome to hear an expert who has taught many of the best speakers in the entire world that this is also complete rubbish that we do this. For whatever reason, in medical training in particular, this has become a fascination to include objective slides at the beginning, which makes me tune out at the beginning of every talk. And so I'm going to leave them up there because that's what we do and not even speak on that any further. So to get things started here, to tell you a little bit about what we're thinking about when we're talking about screening in the primary care office, a couple of things to keep in mind. A big part of doing this is because you all see so many patients. When you have thousands and thousands of kids on your panel and are trying to keep track of some core things, some big time risk factors on a regular basis, it would be wildly impractical to have you ask every one of these questions to every one of your patients. And so this is really where, the role of the screeners were designed for. Some of this was done, and designed for mental health practitioners to be giving for us when we have people admitting. But really, the big time screeners, I think, if anything, have more utility in the primary care office than they do in the individual psychiatric office. When I do an intake for a patient right now, I do 90 minutes in the PHP IOP space. When I did outpatient, it would often be 2 1-hour long interviews. And so just the time frame that we have to actually ask the questions in front of our patients is wildly different than you all get in the primary care space. And so this is intended to kind of break some of that down and give you some head start. And again, this is really the goal to look after the biggest things that we should be thinking about and should be worried about. In some world somewhere, there's a place where you could answer 250 questions every single year just regarding your mental health, and then, another 100 questions regarding your diet and physical movement, and, who knows how many other questions about other areas of health that would be great to monitor. But we also have to, have some level of reasonableness to this. And so we're going to talk about which ones I think are probably the highest yield, most widely used, and a little bit about what those look like. And one of the nice advantages about doing these screeners is that there are people for whom you will not get a great answer from if you ask them to their face, but you will get a different answer if you just ask them to fill out an answer on a sheet of paper. That's not true for everyone. This isn't like a unidirectional phenomenon where everybody finds it easier to answer. Of course, many of you have just amazing rapport with a lot of your patients, and they might have a much easier time talking to you directly than circling something on a sheet of paper. But there are certainly people and adolescents and kids for whom it would be easier for them to circle something and use that as a jetway into talking about a difficult topic. Sometimes these screeners are also going to be used and collected to get population health information. Depending on what kind of healthcare system you look at, that may be aggregated over a much larger thing than your specific practice. And in some cases, they're even used to kind of track progress. And you could use it to like give a risk factor, give a level of how risky a certain practitioner's population is, but also how things are going over time. Now, there are a lot of headwinds going against adolescent and kid mental health. Unfortunately, in this day and age, I think probably everybody who spends any amount of time in the space can talk a little bit about that. Any parent can talk a little bit about that. So there's obviously a lot of complexity to tracking that progress, but these are some of the realm and reasons why people use these screening techniques. So when we're thinking about some of the core ones and that you're going to see, I think the most often, this is not going to be a surprise to anybody, I think, on this call, at least in the beginning, but then we'll get into a little bit more of the excitement after the first one. So the first is the PHQ-9. This can also be done as like a PHQ-2 to try and cut down on the number of questions that somebody is having to answer. And this is just the DSM-5 criteria for clinical depression that are applied into a screening question form. Although it doesn't show it in the slide, there are answers between 0, 1, 2, and 3 that are given to each person to say if this is none of the time, like almost all the time, some of the time, or most of the time. And they give little specifics there for the patients to fill out. And then you get an aggregate score to say how likely somebody's struggling with clinical depression. And in particular, you'll see here question 1 about the mood. It does include the adolescent-specific irritable mood state that is not required or allowable for adults, but does exist in the adolescent space. So this is adapted to the adolescents. And then also in number 9 here, that's of course the SI concern. And so questions 1 and question 9 would be what a PHQ-2 would do. It would get rid of the intervening 7 questions there. And again, just a nice way to have some idea. I think that if you get the PHQ-2 and that comes back positive, oftentimes that would be reflexed then to complete a full PHQ-9. That's a nice way to do it if you have, for example, an iPad or something like that where you can have an if-then contingency. If you're just printing out sheets of paper, it's pretty awkward for somebody to circle yes and not have additional information. So it depends on your practice and what you want to do. You can, of course, then go and ask some of these questions, but answering these 9 questions relatively quick on a PHQ-9, and it's such a standardized questionnaire that I think even most adolescents are getting this even from places like schools, not even including in your office. And so people, I think, are very familiar and quick to be able to fill that out. The second one would be the GAD-7. This, again, is just going to be the criteria for generalized anxiety disorder, particularly in adolescents, that the adolescent adaptation of the words to that. And it's going to also go on that 0 to 3 scale that the PHQ-9 goes on to generate you a raw score, talk to you about how likely generalized anxiety disorder is. I will say there's far more to anxiety in adolescence than generalized anxiety disorder. If anything, social anxiety disorder is probably a bigger concern and probably statistically occurs at a higher rate. There's a lot of controversy over generalized anxiety disorder in adolescence, believe it or not. We've done a very poor job of looking at this data over time. By we, I certainly don't just mean here in the United States. It has been something that has not been well tracked. There is much more funding for clinical depression with kind of obvious reasons. We have lots of concerns about kids ending their lives and how poorly that's gone over the past decade. And even before that, everybody, rightfully so, is always very concerned about things that have these kind of direct correlations to mortality. Unfortunately, that has left anxiety disorders to have very minimal funding, both in the US and across Western medical systems. And so we have much, much less less information on what adolescent anxiety disorders have looked like over time and their comorbidity and the concerns associated with them. Nevertheless, if you do find individuals that are screening high on this, they're typically going to have elevated rates, at least in some of these questions, even if they're dealing with non-generalized anxiety disorders, if they're dealing with, specific social anxiety or some type of specific phobia that's omnipresent in their life. You may even have some individuals with OCD, for example, that are going to still end up scoring relatively highly on the screening measure, although again, is specifically trying to go after generalized anxiety. And again, GAD really needing a lot of additional information to kind of tease apart to get to a true GAD. Of course, if you have an adolescent who's just kind of always on edge and has very trouble relaxing and is constantly sore and irritable, regardless of which underlying anxiety is there, that's not the part that's most relevant for you. It's just figuring out that this is a problem and needs to be addressed rather than the specifics of what exactly is going on. Um, so those would be the two that I'd say I see most widely used in the primary care office. A lot of folks, almost everybody these days are doing a PHQ-2 to PHQ-9. GAD-7, I think, relatively common to see. The one that I really wish we were doing a lot more of, and I think part of this, is just kind of how the zeitgeist of things has been, is screening for substance use. One of the ones that has the most empiric data behind it is the CRAFT. That's just if you take a look on the right side of here, the CRAFF and T, standing for, the car, the relax, the alone, forget, family or friends, and trouble. But if you start, the way that this actually flows is that it asks you the first three questions about in the past 12 months on how many days, and then it just has a box for you to fill in, 0 to 365. And it just gives, a chance to really make sure that the questions are asking about ideally everything that's happened since the last time a patient's been in. Somebody's coming in once a year for an annual physical. This is really targeting that whole, period of time. If you take a look at something like the PHQ-9 or the GAD-7, they're asking for more recent symptoms, and the intention of that screening tool is not to ask about the last 365 days. It's a little bit of a tough part about it when you're seeing somebody only once a year, as opposed to something like the CRAFT, which again is verified and validated in the adolescent space, and also intentionally going after everything going on in the past year. And then it gives them just like a very simple yes, no. So this can again be filled out in the span of, a handful of seconds once somebody is familiar with what's going on, and widely applicable, widely shown to be an effective screening measure. I do think this is an area that's heavily under touched on and underdone in general pediatric clinics. If you take a look at the risks facing modern day adolescents, the substance uses are very high on the list of overall mortality and morbidity across any medical condition that your patients could be struggling with. And so I think, in particular, anything that we can be doing to make sure that we're identifying this earlier and helping graft some intervention earlier can end up making a really big difference in the substance use space. So in addition to that, there are certainly broader and other screening measures that can be used, but I think it would be hard pressed again to come up with somebody having to fill out 100, 150 questions when they come to see you for a primary care intervention. If you did want to take a good look at social anxiety, there's the SCARED, very empirically well-validated adolescent and child screening tool that is very specific for social anxiety disorder, but it is a lot of questions. It is something resembling 40 the last time I took a look at it. Not going to be a fast thing that I think is going to be a generalized thing. But if you do have somebody coming in where the chief concern is some issues, with school avoidance, hiding, getting away from people at school or in other places, you just have talked to them and they're having these fears of embarrassment and judgment from peers. This is a nice thing to be doing, specifically for patients who are struggling with that, and a nice screening tool there. The Vanderbilts, I'm sure every single person is aware of. I think it would be a lot to give this again to every single patient that came in. But if you have any concerns about ADHD, Vanderbilts are Vanderbilts, and I've never met a pediatrician who's not familiar with the Vanderbilt, so I'm not going to spend a lot of time talking about it. It's an excellent scale. It's free to access, unlike something like the Connors, and it's used so widely for very good reason. Does a very nice job. Ideally, of course, you're going to want a parent report, as well as a school report on these rating scales. They're pretty straightforward. If anybody has any questions, happy to talk about the Vanderbilt. Now, some of the things that you might be a little bit less familiar with or seen a little bit less often are some of the things relating to eating disorders, overall clinical functioning, and then trauma. So the E26 is a pretty good child and adolescent eating disorder screener, really taking a look at attitudes towards food, risk factors for eating disorders, and then actual symptoms of eating disorders themselves. Again, another area where there's a lot of morbidity and mortality in the adolescent space, something that has also absolutely been on the rise in the past 5 years. COVID and social media, kind of the combination of the two, have really led to significant increases in eating disorders in the adolescent space just since 2020, and had already been, one of the most mortal conditions that an adolescent could have. Historically, as a common test question to answer, at least in the child and adolescent psychiatry space. And so definitely an area to be trying to think about and pay some attention to. You guys have the great advantage of growth curves, which can certainly give you a lot of information in this space, but certainly there are some other things going on other than just raw weight and height values and growth curve changes that this can kind of tip people off and allude you to. And certainly I think a lot of parents have some semblance of this being a problem. I have seen many patients because I do a lot of initial evaluations for eating disorders after somebody's been referred by oftentimes a primary care doctor. And I know the chief complaint for that visit is going to be something like weight loss, that kind of thing. Of course, you guys have a more complicated job of ruling out all the other medical conditions that could be causing that weight loss and have to go down those pathways as well. I get the easy job because you've already done all that hard work for me by the time they typically hit my door. But as part of that, we certainly want to be thinking about the psychiatric eating disorders in addition to any medical cause for weight loss. That's a nice way, if you know that it's a focused visit for that as opposed to a broad screening, to get some information. The strength and difficulties questionnaire is one that you'll see used in a lot of mental health places. So like when kids come in to say UIC and are having a lot of issues for like an overall screener, this is something that can just give you some idea. Talks about like how happy a person is, but also how many problems they have if they're having issues with family, with friends, at school, and a whole host of different subdomains, really just asking about functional impairment, which is at the end of the day what we really care about in child and adolescent psychiatry. Of course, your emotions and your thoughts and your feelings, they matter. I do care about those too. But what's really, really going on, what we're really, really looking after is kind of how much is it causing you problems in your life in demonstrable ways. And this is trying to just give you some, a quick outline. If you did feel like you had a practice where you wanted a more generalized screening tool and you did feel like, your patient population was happy to fill out a bunch of questions, I think that's in like the mid-20s, but they're very quick questions. And it would definitely be a broad-based, appropriate screening tool if somebody felt like they had a practice that was going to support that. And then the last one, it comes in the child and adolescent trauma space. There are a number of different screeners here. This is excuse me, I believe out of UCLA, if memory serves, and they've done a lot of research with the screeners in the space. Child and adolescent trauma screening is going to give a whole host of different traumatic situations, from natural disasters to inflicted by other people, and physical, sexual, emotional violence, all of those kind of things. And it's just a yes, no on the first page of like, did any of these 12, 14 things ever happen to you? And then if yes, it would kick out a second page where it's going to have a whole host of different post-traumatic stress disorder responses that people can have, and ask somebody to clarify that. So this is another one of those ones where if you have access to an electronic system where you can have kind of the if-then sort of contingencies, where if somebody just quickly is clicking no to everything, it's just done, it goes away. When somebody does click yes, then it comes out and gives you that second part of it. If you have those kind of systems built in, I do think this makes a whole lot more sense. I wish there was a shorter one, and I honestly probably should do some more research to figure out if anything's been done. Again, a lot of times these things are first created for mental health research programs, then used kind of in psychology, psychiatry settings, and then interestingly enough, I think they have the best utility when they're done correctly in the primary care offices. But that's just not what a lot of these psychologists and psychiatrists who are working on this are thinking about. And so the number of questions that they contain can just be a big barrier. But there are a number of trauma screens, and again, an area in which, even if you don't see PTSD itself, acute stress disorder itself, those kinds of childhood traumas, when they occur, can cause issues across the board, both in physical and mental health going forward, and can contribute to virtually every other psychiatric mental health symptom. Okay, so you've come up with what you want to do for screening your population, or maybe the organization you're working with tells you you need to screen. Okay, so then what do you do once something is coming up positive? Well, again, I know many of you have somewhat stable patient populations where you know folks fairly well. You're certainly going to look for any new changes, things that are different, new impairment, whether it be at school, with family, with jobs, relationships, things that are demonstrably different than the last time you've seen the patient. If there's been any abrupt changes in social group, peer group, a very common sign of things that happen with depression, with social anxiety, with substance use disorders, with eating disorders, with trauma disorders. Almost all of our core disorders can be things that lead to significant changes in peer group. And then, of course, the classic maladaptive coping skills of adolescence to be thinking about. So things from self-injurious behaviors to eating disorder behaviors to substance usage to compulsive behaviors. And then a lot of the new age addiction, particularly social media and video game addiction, starting to come up, pornography, and other sexual-based ones, always harder to get teenagers to talk about, but certainly also on the rise in this space. Ideally, you're grabbing collateral from other parents that are there. If there's big concerns, of course, reaching out to the school or the therapist to get some additional information. And in the office during the brief period of time you have is, of course, assessing for the acute risks. So suicidality, concerns with overdose, intentional or unintentional. If you've got patients who are starting to get pills off the street, relatively common phenomenon, unfortunately, very high rates of contamination with fentanyl. So these are things that, really need to have acute responses to if you're finding out some information on. And then, of course, with eating disorders, the acute nutritional deficits, electrolyte deficits, changes in vital signs, all of the acutest things to be thinking about in the moment. And then, largely it's the triage process that you guys know infinitely better than I do from your daily work of just figuring out, okay, like I know this is a problem. Obviously, I'm not going to be the only person addressing this for my patient. So what comes next? Figuring out, what appropriate referral sources are around you, kind of feels like that second job, I think, for a lot of docs of figuring out who are the people that I can trust and get help with, from psychotherapists to child and adolescent psychiatrists to dietitians, to, higher level of care treatment centers. And then obviously, if you've got peer supervision, I know we as doctors at SunCloud meet at all of our sites, virtually every week to talk about cases. Obviously, you have almost all of you work in practices probably where you have a lot of other pediatricians to bounce things off of. If you've got a child and adolescent psychiatrist you feel comfortable, shooting a message to, reaching out, phoning a friend. I know I'm always happy if my friend who's a pediatrician reaches out to me, mostly because I have way more questions about pink eye than he will ever have about depression. And so I'm always thrilled to get messages from my pediatrician friend if he reaches out. So feel free, to use some of those resources, and of course, things like us if you do need to. And then, in the Chicagoland area, we do have a lot of options, thankfully, particularly for patients who have commercial insurance. So again, just to give you that brief overview of levels of care, treatment, and what that looks like in modern mental health practice. Again, something that was definitely not part of my med school curriculum or my med school rotations. Everybody knows about outpatient. That's, of course, going to be your outpatient child and adolescent psychiatrist, your outpatient psychotherapist, outpatient dietitians, if you're dealing with eating disorders. So lots of options there. Obviously, you guys have your own subspecialists in adolescent medicine and things like that, if things like that are relevant and appropriate. And then any other standard outpatient care. Again, everybody knows about that. I don't know why I'm trying to still talk about it. The next level of care up from there is intensive outpatient treatment. And so that's going to be for adolescents or even kids who need more help than a standard, 1 hour a week kind of psychotherapy. But for kids who typically are still doing well enough that they can consider being in school. So most IOP programs during the school year, so for about, 10 months of the year, they're going to run after school hours. So like roughly 4 to 7 is what ours runs. I think most good IOP programs have something similar like that set up. So this is really for a kid who can go to school the whole day, make it through the whole day, but then is still needing that extra help and that extra support. IOP programs, there's a slide for that. IOP programs do not necessarily require psychiatric intervention or services at all. So this is a big difference from all the other levels of care. There are IOPs run just by social workers, just by psychotherapists. I'm certainly not saying just to be diminutive to those excellent and very important professionals, but just does not have an MD level of supervision and oversight. So certainly if you have somebody where you have concerns about, complex medical comorbidity, differential diagnoses, of course, medication, management of issues that are coming up, IOP is often not going to be the case. Now, there are IOPs that do have psychiatric involvement, IOPs like ours, where all of our IOP patients are still seen every week by child and adolescent psychiatrists. It just depends a little bit on the ethos and the practice style of the program you're referring to. So it's a good thing to know in advance. Again, if you're taking a look at different programs, if you feel like somebody's going to need the services of a psychiatric clinician, IOP, is variably going to be the option there. I will say I get a lot of questions about IOPs from families, from patients. Holy cow, how long of a day is it? And the answer to that, of course, is yes. It is a lot more to ask of to go to school from 8 until 3, get in a car, drive to an IOP, do that from 4 to 7, and get home at 7:30. You got a patient who's gone, probably 12 hours, from their home, doing a lot of stuff over the course of the day. That's more than we ask of most adults. And I think being open and honest about what's actually at stake there is really important. But, a lot of kids really do want to be in school, really can be in school, and they do benefit from this treatment. I see it all the time on a daily basis in front of me. It is something where the schools do a really, really good job, at least in the area that I work in the northern suburbs. Almost every school, honestly, from the middle schools to all the high schools, they all have their own teams. They all do excellent work working with the teachers, reducing course load, reducing homework amounts. And typically, patients' grades are actually better than had they not done treatment in the first place. One, because their mental health is better, but even two, and probably more importantly, because the school is making significant accommodations to what their course load is looking like. What's actually happening at treatment, we're doing largely group-based psychotherapy. That's going to be true for every level of care that is not outpatient. So that is a big thing to keep in mind. Many people report that they have big concerns about this. I think when group therapy is done well, it is rarely something that's going to be, particularly, tough or difficult. Even for survivors of very severe and horrific trauma, we very readily find ways to make the more nuts and bolts trauma work be done in an individualized way, but still have the groups available to help and support, talk about symptoms, talk about what people are comfortable talking about, and find it highly efficacious. And so again, you're going to see this in IOPs, inpatients, PHPs, residentials. They're all going to be group psychotherapy based, but each patient will still have individual sessions with their psychiatrist, with their therapist, and with dietitians when indicated for people with eating disorders. So PHPs, or partial hospital programs, they're also known as day hospitalization treatment. Those are going to run about 6 hours instead of the 3 of IOP. So roughly 9 to 3 at SunCloud over the summer, 9 to 3:30 during the school year, because we give the kids an extra 30 minutes of school in some programs. And this is always going to include at least once weekly psychiatric psychiatric evaluation. So something where if you think somebody needs to see a child and adolescent psychiatrist, every PHP program that exists, at least in Illinois, will be required to have a psychiatrist seeing the patient. Kids are medically excused from school. So just like if they broke their hip and had to go to, a rehab hospital all day, and be the same thing for us here. PHP is dramatically more so than an IOP. Again, we offer 90 minutes of school a day. Sometimes they do 60 minutes, but you're going to get 60 to 90 minutes of school every day over the course of the PHP program to get done kind of the nuts and bolts essential schoolwork that the school has distilled down to. But we really ask them to keep the amount of homework beyond what would be expected to be completed in that 60 to 90 minutes to a real minimum, somewhere in the vicinity of like an hour at the most. I think in high school would be kind of the range I'd be targeting and expecting for a patient to do after they finish a PHP day, because kids who are in PHPs, they're really struggling. There's a lot going on in their life. There's a lot going on inside their head. And we really want them to have that time to focus on their mental health, get themselves back into better shape, but still understanding, of course, the core nature of high school and how it has to keep moving. And so finding ways to build that bridge, make sure they're still able to learn what they need to learn, so they're not woefully behind, when they get back, but also not overwhelming them. And again, this has been an area that historically, back when I was a teenager, was nothing like it is now. Almost all the school districts, particularly in the suburbs in the Chicagoland area, just do a fantastic job managing this and making sure that kids don't feel overwhelmed when they get back and get really nice support. During the course of the day, we're of course going to be talking about adaptive coping strategies, CBT skills, DBT skills, dialectical behavioral therapy, ACT, acceptance and commitment therapy. There's a host of other psychotherapy techniques that are also taught in this setting. But then one of the things that's a little bit more different about SunCloud is we'd also be focusing a lot on conversations about what's actually going on in your life. So for us, we call it process therapy, and it's really a place for kids to talk about, the hard things that are happening in their life, be able to talk about their emotions with it, their experiences with it, and just really be able to dive into, have an open space to dive into the tough stuff, right? It is not easy to be a 15-year-old and sit down with a friend and say like, hey, this is what happened when my dad punched my mom, or when I got sexually assaulted, or when I thought, man, wouldn't it be great if I could, just cut my throat and die. Really hard to have those conversations with random people, even very good friends. And we work really, really hard to make sure that kids, adolescents can have those conversations with other peers, in addition to psychotherapists being in the room to help direct those conversations. And so people can actually talk about what's actually happening in their life, which is badly, badly missing in a core function of treatment, particularly with us. Residential treatments, just to quickly cover, the name is pretty self-explanatory. It's the place that you reside in. So it's going to be 24/7 care. There's going to be on-site nursing, of course, lab draws, psychiatric services on a regular basis. The adolescents who are going to need residential are really for adolescents who are struggling to abstain from substances, even when they're getting PHP levels of care. They have lots of issues at home, repeated police involvement, fights, altercations, things like that they're struggling to eat without all their meals being supported. They maybe eat when they're at a PHP and then eat nothing when they get home, or they get home and they purge anything that they do eat, and families not able to support them through that. And also for adolescents who just simply can't get out of bed, can't make it happen, whether it's from severe anxiety, agoraphobia, severe depression, and things are just not going away for them to get out of the door in the morning to get to a PHP program. Those are all really good indications for doing residential treatment. Just to be clear here, residentials, when I'm referring to them, are talking about medically supervised, Joint Commission reviewed processes that are going through commercial insurance. There is a separate industry that is not driven by physicians and medical providers. Sometimes they call themselves wilderness programs, but they often will use the name residential as well. So you're looking for, actual medically done programs that have medical directors and are reviewed by the Joint Commission and all those kind of things when you're talking about this type of services. And these are, things that are covered by insurances, as they should be for medically necessary treatment of severe mental health disorders. I will briefly add, because I get asked this a lot, residential treatment does require an adolescent's consent, I believe in 48 states in the union, not Utah, and I believe it's New Mexico, but it's one of the other states out in the West. I'm sorry, I'm a Midwesterner my whole life, as my background may have indicated. I'm not uber familiar with out there. So I have had some patients that have been flown out to these states that do not require their consent to engage in residential. Those are some pretty ghastly spots when you get in there, although sometimes have been actually able to turn around. But this is something that, again, we're talking about in like kind of the voluntary space of things. Although obviously adolescents can be strongly encouraged to do things based on, what privileges they're allowed or not allowed to have. Residentials do also have their own exclusionary criteria. They're typically not going to work with adolescents who are acutely suicidal, who are strongly aggressive or struggling with psychosis. Those are going to get kicked up typically to an inpatient unit, and then after stabilization there, they may be able to be stepped down to residential treatment. Inpatient units, I think many of you know, probably looked a lot different 20, 25 years ago than they do now. Nowadays, the average length of stay is probably 5 days. It was probably 30 days 25 years ago. It's pretty hard to cut off 83% of the average length of stay and have it expect to stay the same. Inpatient is really not trying to solve anybody's problems. It's not going to fix like some major issue in an adolescent's life. The goal is to get something stabilized enough such that they can go and get it fixed at a PHP, at an IOP, at a residential treatment center. That paradigm shift has, slowly been happening, but for anybody who's not heard it directly, I think just important to know what we're actually dealing with there. Of course, inpatient units are wonderful places for adolescents who are acutely manic, acutely psychotic, who are struggling with severe eating disorders and require tube feeds and regular, electrolyte monitoring, and have wonderful adolescent medicine pediatricians around to help make sure that they don't die, and have cardiac monitoring. And there's a whole host of great reasons to be on inpatient units, but largely mental health, psychiatric treatment is just in a stabilization kind of phase for inpatient care. So, when you're thinking about that referral process, like, hey, we're screening positive, I'm talking to this patient, I know they have real issues, what do I do? Just a few things to keep in mind. Different organizations are going to have different strengths. Nobody can be great at everything. I'd be very leery of anybody who told you that they could. So some places might specialize in substance use disorders, eating disorders, like we do. Some places might specialize in self-harm. We do some of that, but certainly are not. That's not our hardcore bread and butter specialization. If you do need a residential for that, Midwest Center for Families in Indiana is definitely the Midwestern place that specializes in very severe suicidality and self-harm. Places will specialize in mood disorders and anxiety disorders. Pathlight is one example of those places around here. There's also Southern Wisconsin, Rogers Place that just focuses on mood and anxiety. OCD, also a specialization of Rogers, and trauma. I don't know of any that are 100% trauma focused. We do a lot of trauma work. Certainly Newport Academy does a lot of trauma work, but there are going to be, different places that are going to have different areas of focus and specialization. Some of these are not going to offer all levels of care. For example, unfortunately, right now we have PHP and IOP. We do not yet have adolescent residential services, although I am told that those are coming shortly. And I'm looking forward to being able to offer that to the Chicagoland area. In our adolescent space. Different places are going to have different things. It's particularly relevant for places that you may have, like, for example, an IOP and not a PHP. Rosecrans comes to mind for that in the area locally. And so, there are places that are not necessarily going to have all the levels of care that you'd be looking for. So it's an important thing to have a vague idea of when you're making that referral. And then certainly if this is something where you have a lot of information you want to provide, you want to stay informed. I've had some really fun conversations with some truly incredible pediatricians who have really been helming their patients' eating disorder, even while they're still working with us here. Certainly, all of our doctors are more than happy to be in contact with any of the referral sources. Of course, we know you have packed days. If this is something where it's you getting them to us, and then us doing the work, and then sending them back to you in a much better shape with a nice handout, that's certainly a common occurrence as well, and not something where you necessarily have to be heavily involved while you're doing the work with us. But certainly, if that were something that came up and you did or had a lot of helpful information or just wanted to know what was going on, we're always happy to be in touch with our PCP colleagues. So that's all I have for you today. I intentionally am trying to give ourselves 20-ish minutes. Any cases that any of you want to talk about, and then also any barriers to care that you have seen. And again, I'm open to any real conversation here. If there's anything anybody wants to talk about, I'm happy to talk about new medication, psychopharmacology, the scourge that is social media on our youth, pediatric bipolar disorder, you name it. I'm usually pretty happy to have the conversation. So thank you all for coming again. I know it's Friday afternoon time slot. There's a lot you could be doing with your time. Thanks so much for coming, and really happy to answer any questions about screening, referrals to higher levels of care, or just child mental health in general.
We do have something in the chat, which I mean, I can answer, but I'll let you answer, Dr. Chevalier.
Sure.
Doctors having privileges, are doctors having privileges at any of the acute hospitals?
Yeah. So we do not have privileges at any of the psychiatric inpatient units, which is pretty typical across the board for people in PHP and IOP programs. There's a couple rare exceptions to that, like out at Linden Oaks, where they have a more combined model. But for the most part, PHPs, IOPs, and even residentials are really functioning independent from the acute inpatient units. Of course, anytime we're transferring patients back and forth, we're always calling, hoping to speak to our colleagues, and the trauma analysis and psychiatry that are receiving the patient, and obviously hoping to get some information back when they finish seeing the patient. But no, for the most part, you're not going to have inpatient privileges. And honestly, I think at least for us in the area, it ends up really not being a big deal. We work regularly with like the trauma analysis and inpatient units. There's not that many of them. And so the places that we actually refer patients to is like 3. And we know a lot of staff there. We go to talk to them on a regular basis. Some of our staff have like some of the therapists at Highland Park's inpatient unit, like on speed dial, for example. So it's not, a tough setup by any stretch of the imagination. Even though some of these people have their own programs, they're always still referring patients to us. We're referring patients to them. It's a really small world once you get into the higher level of care, adolescent mental health space. And so, I'm curious if you think that there's any concerns or issues related to that, but thus far, for the last 4 years while I've been here, it really has not been an issue. Thanks for the question.
Any other questions or any kind of cases that you guys would like to discuss, or things that you're seeing in your practices that you'd like to share? I
Yeah,
know this is like the busy time for you guys, obviously, with school physicals and just that yearly physical. So I again appreciate you guys all stopping in.
certainly welcome to chat as well. We can allow you to talk if you'd like to. If you have
Yeah.
a longer conversation that's not fitting in 140 characters or less, so feel free.
Okay, I don't know if there's any other questions. Obviously, like I said in the beginning of the presentation, I will follow up with everyone and just kind of thank you again for coming. I oh, okay. We do have something. Do you see it, Dr. Chevalier?
Yeah. Yeah, that is a great question. Online services. I am not overly aware of the online trauma space. I will tell you, trauma therapy is very unique compared to all other forms of mental health psychotherapy, and is the only form of psychotherapy that has been repeatedly shown in clinical trials that it is capable of causing harm to the recipient. Trauma work is not straightforward or one size fits all, to say the least. And so that would be an area that I would have very significant concerns about using like an kind of like standardized or AI based treatment for. When you take a look at even poorly done CBT for depression, anxiety, we really have never had any studies come back and show that kids do worse. And this is the one area that we have seen kids who've done worse for with poorly done trauma psychotherapy. So, in my mind, this would be a lot more about finding ways to get them connected to people in the community that they could find and access. I don't know if there's going to be language barriers there, and that's going to need to come, through anybody in that's able to speak, whether it's Ukrainian or Russian, the languages and any community services around that. We can certainly have our team look into that for you. I do not have an answer for you here today. If the kids are able to, be relatively conversational in English, certainly a great place to have them be seeing, an individual therapist at the very least, for that initial evaluation to see if we think we need, outpatient services, higher level of care services. But yeah, we certainly, unfortunately, have had a lot of kids experience a lot of trauma. I'm sure, over the years, in a whole host of different domains from war. And so definitely an area that's, well researched, well understood, how to address in the pediatric mental health space, but not anything that I'm aware of online. And I would definitely be a little bit leery with that.
I can say though, like with the influx of like immigrants from everywhere, honestly, schools are really trying to do more in their buildings to help support these students and families. And so I would always encourage, like, first to check with the schools, because they're in touch with obviously private practices and different programs. And so I see like some schools are, I mean, they have like in the area, like someone that speaks Ukraine on staff. And so like then that is like, and it can be a teacher, it can be someone from the cafeteria, like whatever. They're all like they're trying to utilize any resources to help these kids, like and families, like parents coming in that are struggling with kind of the communication to ensure that they're getting what they need. Because obviously it's traumatic and there are a lot of services that are needed and sometimes not available. So just trying to really like get more information out there. And so I know schools, like I'm in schools all the time. It's something that they're really trying to push and trying to get more information on and practices in the area, meaning therapists and obviously psychiatrists in the area are trying to help support that. And so they know which ones are really on top of it. So if you need any help with that, feel free to reach out. Again, thank you so much, Dr. Chevalier, for sharing your wisdom and talking about this, because I do know that being out and about in the community, this is something that I think we all can use some support and knowledge on. It's ever changing, like you said. I worked at a hospital years ago and they were staying in inpatient for weeks at a time, and now it's like three to
Sure.
five at the
Mhm.
most, right? So
Yep.
we see
Yep.
the change.
Okay, thank you all for coming. Really appreciate the work, all you're doing out there. If nobody's thanked you anytime recently, I want to personally thank you for all your hard work. I have very few classes of people in the world that I like meeting more or appreciate more than pediatricians and primary care doctors. So thank you all so much for the work that you do day in, day out, and thanks for coming on this Friday afternoon with us here.
Thanks, everyone. Have a great weekend.
Take care.